Hello, everyone. I feel that today's topic is extraordinarily important. I have been privileged for the last 30 years to take care of a lot of female patients. And when I sit down with a patient, of course, they come and seek my expertise from a dermatological standpoint, whether it's a skin check or a breakout or skincare routine, or then in many patients, facial rejuvenation. We talk about a lot of personal and very intimate issues. And not infrequently, patients will find that this is the time when they can really focus on themselves. And I hope that they have the comfort to bring up topics that at times do not get discussed but so important. And today we are going to talk with Dr. Arnold about postpartum depression. I take care of patients in different age groups. Many young women have ended in the room seeing me for different dermatologically focused reasons. And inadvertently, whether they brought it up themselves or there were signs that I have picked up on and brought to their attention a potential and a possibility of discussing postpartum depression, we would engage on the topic. So just the other week, I had the honor of hanging out with Dr. Arnold, and we were talking about what's really of utmost importance to us, taking care of patients. So I have asked Dr. Arnold to join me and talk about the area of her expertise that she'll tell us about. But before we get there, tell our viewers about you.
Well, Dr. Paré, I've lived in Atlanta for over 25 years now, and I did my residency and my fellowship training at Emory University, where I studied the psychopharmacology of mood disorders in women, particularly in women who were pregnant and postpartum, and that's how my career started. And then I worked at Emory for a little while. I was an assistant professor in the Department of OBGYN as well as psychiatry, and I took care of women at Grady and at Emory, so I got a lot of really good experience. And then after I had my third child, I started my private practice.
Oh, wonderful. Well, I know that a lot of our patients have connected with you. It's wonderful to be awarded by recognition as best in Buckhead, but most importantly, it's so rewarding to be recognized by patients that come to you. And I know that psychiatry, mood disorders is a very broad topic, but let's focus a little bit more on your area of expertise on postpartum depression. So let's talk a little bit first about the signs. How does the patient come to you to begin with?
Well, unfortunately, I typically get a patient when they're in pretty bad shape, when their OB has already discovered that typically they're postpartum and they're having a really hard time in the postpartum period. I want to let people know that these symptoms actually start in the pregnancy.
So talk about the symptoms specifically, because I know that you mentioned to me that it's not just true postpartum, that in the throughout pregnancy or towards the third trimester, and what are the symptoms a little bit more specifically?
One of the primary things that people need to look at is their sleep patterns. That is a very big sign. If you're not able to get sleep, if your sleep patterns have changed, if you don't feel rested when you wake up in the morning, that is a sign that something is going on. And oftentimes people will put these off. Especially after they've had a baby, they're like, well, of course I'm not sleeping.
Right.
But they're not getting that rejuvenation that their brain needs. And so that can aid and abet a postpartum episode.
So sleep deprivation.
Yes.
Any other sign or symptoms that should alert family members, a provider, or the potential patient themselves?
If the patient, during the pregnancy, there's certainly you can become depressed and anxious. If the patient doesn't feel like they're taking very good care of themselves, or if they've started self-medicating. Sometimes patients will actually self-medicate with drugs and cigarettes and alcohol while they're pregnant. That is a very big sign that there's some danger there, okay? And particularly, like I said, if they're not taking care of themselves, if they're just becoming more and more tired, if they're not interested in things, if they don't feel a connection with the baby, those are some very big signs of postpartum depression. One of the things that can aid and abet this also is marital discord. And it's important to be honest with your OBGYN, because oftentimes that's the only person you have to talk to. If your husband is, if there's marital discord involved and there's some things that you don't agree with the way he's treating you and things like that, or the expectations that he has, you need to talk to someone about that.
And we're lucky that we've practiced for many years, and the understanding of mood disorders, of course, has changed so much. But still, for so many patients, they feel like this is a little bit of a stigma to talk about feelings, particularly for young mothers.
Yes.
or new mothers, young and older. That these are feelings that they should not really be feeling, and they're afraid to discuss. I guess we do encourage them that this could be a normal change.
Well, and the other thing that people are scared of also, if they're having what we call incongruent thoughts, and what that means is you love your baby. You can love your baby, you can feel attached to your baby, but then you may be having thoughts of actually hurting your baby at the same time. And you can't explain that to anyone. People don't understand. And people are scared to say that out loud. Women are very scared to say that out loud, because at that point they don't know who they can trust.
Right. I mean, I could only imagine that these are such perplexing feelings that are not well understood. Do we understand now a little bit more why this happens at all?
Well, there are actually several different reasons why it can happen. Certainly, if you have a history of depression or anxiety going into your pregnancy, you are at a much higher risk than other women are, okay? Sleep deprivation is a big thing. Marital discord is big. And it's not necessarily about your shift in hormones. The shift in the hormones is more of an issue in the immediate postpartum, and that's what we call the postpartum blues. And most women will experience, like 80 to 90% of women will experience the postpartum blues, and it comes and it goes. If the postpartum blues are not over by day 14 of your postpartum, then you are going into a postpartum depression, and it needs to be addressed, because if it is not addressed, it will not get better on its own.
So that was my next question. Do you just kind of write it out, or do you want really active help to get better?
The problem with writing it out is that it will get so much worse that eventually I have found that you're not even in the right headspace to seek out help. So if you feel like something's going wrong, you pick up the phone and call your OBGYN's office and speak to the nurse there and tell them what's going on. You don't have to tell them what your thoughts are.
Right.
You don't have to tell them specifically what your thoughts are. But all of the OBGYN's offices, especially here in Atlanta, we're very blessed, know who to put you in touch with.
That's terrific.
Yes, and reach out and get that help, because it will, I can't enforce enough how much it will not get better on its own.
So let's talk a little bit about the treatment that happens when patients present. They're referred to a psychiatrist. Is it medical treatment? Is it sessions with a psychiatrist? Or I would imagine probably a little bit of both.
This is what I like to do with my patients, and I learned this when I was at Emory. I had the value of, while I was doing my fellowship, I could have patients come back every day if I needed to.
Right.
But that very consistent, heavy attention to the patient was very important. Typically, patients need medication. There is always a psychopharmacologic aspect to this, okay? So I go through a list of medications that could be helpful to the patient for this, okay? And then I get them some sleep. I give them some sort of medication to get them to sleep.
Yeah.
And I also talk to them. They don't need to be taking care of the baby all by themselves all night and trying to breastfeed the baby and up all night. And so we have ways to teach them how to do that also. And I keep in contact with them, particularly in the beginning, and it's so helpful. And they text me every day and call me when they need to.
Yeah, and I think that's so important that patients understand that yes, they can get better.
Yes.
but it requires a little bit of work.
Yes, and it requires work on the part of the family also.
That's exactly my next question. So typically, would you involve members of the family, not
Yes.
necessarily always the spouse?
Yes.
I mean, hopefully that there is, an extended support system.
Anna, do you know that in cultures where families don't move away from each other, where everybody lives close together, there's no such thing as postpartum depression?
Yeah, I'm sure that feelings of isolation and feeling alone definitely contributes. I'm glad to hear that we are not blaming everything on hormones, that there are so many multifactorial elements that come to this. So when you do see patients and they are on treatment, typically how long do they stay on the treatment? I know every patient is an individual, but just
there are
grasp.
very specific parameters around this, okay?
Right.
It is necessary for, if a patient starts an antidepressant, you must be on that antidepressant for a year.
I see.
Okay? If the patient only stays on it for 6 months, there is a 50% chance that they will relapse, because it's a matter of your receptors in your brain accepting the medication, working with the medication, and if you pull that away too fast, it all goes away. It disappears. So it does require a year of treatment. Oftentimes, I will suggest that I have very good therapists that people can talk to depending on the level of care that someone may need. And I'll tell you something else too, Anna. There is, if someone is really, really sick, there's a treatment that I've been sending people for, and it's ketamine. And ketamine is an amazing treatment modality for women with postpartum depression.
So is it typically administered as an outpatient or inpatient?
Outpatient.
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 Say a few words about that so we can learn a little bit, because I know ketamine is not used only for that purpose.
Right.
But
Ketamine is used for treatment-resistant depression. It's used for post-traumatic stress disorder. It's used for a lot of things. The most you go to a doctor who specifically specializes in giving ketamine. It's an IV infusion. It takes an hour, okay? It's a good idea to go in the afternoon. You go home, you rest, and literally the next day, I have patients that go back to work after they've had ketamine infusion. But what I explain to my patients is people have automatic thoughts in their head. But unfortunately, these automatic thoughts are attached to feelings, okay? And the ketamine somehow magically detaches the thoughts from the feelings. So they might still have the thoughts, but they don't have the feelings that go along with them. And I have found it to be life-saving in some of my patients.
So much easier to manage.
Yes. And an antidepressant can take a while to get on board. But if somebody is really in a very bad place where they really are thinking about hurting their baby, rather than being hospitalized,
that may be a great tool.
Yes, they can go and get some ketamine treatments and they will feel better in no time.
And I love hearing that, of course, long-term tools, but there are things that you're doing now that can be acting a little bit quicker and really can bring a lot of relief up front.
And then the mommy doesn't have to be separated from her baby either.
Yeah,
she doesn't have to go into the hospital and be separated from her baby.
So important. I know that that you have a lot of patients. Lately, you've been in the news for, as an expert in some very sad cases. So I know that patients across the country have reached out to you and have shared their stories. And I hope to hear from you that many of those have a very positive end.
Thank you.
Yes, so I hope that they've come as inspirational stories, that women do get better. And when they reach out for help, they do get better.
And don't be scared to reach out for help, because you can get better. You don't have to feel this way.
So, from our standpoint, we are providers that care. Reach out to the ones that you feel like you have confidence that can give you a directive, that they can give you a referral to many of our wonderful specialists. Dr. Arnold, thank you so much for joining me. This is such an important topic. We are here to help, and thank you again for being with me.
Thank you.